respectable chairperson, ma'am, who has gone, my dear colleagues, ladies and gentlemen, assalamu alaikum. सबसे पहले तो चीमा साहब का, आफ्ताब साहब को और आपकी सारी टीम का बहुत शुक्रिया for giving me this opportunity. I think credit goes to you for arranging such wonderful academic sessions, to have so senior faculty members over here. So all praise for you. The topic I'm going to share with you, the challenges in the diagnosis and management of cervical carcinoma. You all know this is the third most common gynae problem after endometrial and ovarian cancer. If you look at these images, I'll just move this cursor here. Irrespective of the age, as you go from the fundus down to the cervix, you can see here the vagina, the external os. The cervix starts gradually decreasing in transverse diameter and in the epidiameter. It's half of this fundus over here and cervix. So that means this diameter should be less than 2.5, 2.3 centimeter in a post-menopausal woman. If it is enlarged, look at this again, its fundus is high, gradually coming down level of internal os, and there we go in the external os, and this is epidiameter is 2.4 centimeter, and well-defined smooth outline, tapering gradually uski hoti hai. So that is a normal cervix you should appreciate on transabdominal and on transvaginal route. But if you add a 3D ultrasound, just one click away, you can see the entire endometrium starting from the fundus down to the cervical canal. And if there's anything wrong, irregularity, especially at the margins, you can appreciate that. In this case, you can appreciate the small echogenic focus, which is basically a polyp within the uterine cavity and not a mass. Just to show you the how the images they look like on ultrasound and MR. Look at the cervix and look at the MRI. You can appreciate this uterine cavity, and that is cervical canal. Very nicely appreciated on the coronal as well as the sagittal and the axial sections. And if it is irregular, thickened, then now let's start how the presentation of the cervical cancer. It may be younger age, often asymptomatic, post-coital vaginal bleeding, abnormal vaginal bleeding, and profuse malodorous vaginal discharge, is foul-smelling discharge. If you find these three things, one should start worrying for this cervical malignancy. There are multiple causes of bulky cervix, maybe cervicitis, the most common. It can be cervical fibroid, it can be endometrial polyp, it can be Nabothian cyst, it can be cervical ectopic. These days we are looking for it. Or these are the malignant conditions, and out of that, 90% is squamous cell carcinoma, which is the ectodermal origin, which you can see downstairs. So I limit myself only to how to diagnose this malignant condition, and I'll omit this benign condition because of the time. We all know by the latest classification of cervical cancer, there are 4 stages, 1, 2, 3, 4. I'll just show you image here, 1A image. The tumor is limited to the cervix. There you can appreciate the cervix, and depth and VH determines the substaging. And it has to be less than 3 millimeter or more than 3 millimeter in 1A, and 1A2 if it is more than 3 but less than 5 millimeters. Similarly, 1B, if it is limited to the cervix, but the depth of this invasion is more than 5 millimeter. That is 1B stage. 2 stage, if the tumor involves upper third of the vagina without parametrial involvement, then you can appreciate the upper third of the vagina is involved, but there is no parametrial. But if you go to 2B, 2A, only this side wall, but if you see the parametrium, including the parametrial involvement, that is stage 2B. Stage 3, the lower vagina is involved without pelvic wall. And stage 3B, it not involves the vagina but involves the pelvic wall, and that involves the base of the bladder. With the result, there is hydronephrosis. The first thing involved picks up as the extension to the bladder is the base of the bladder, where all the ureteric jets are entering and that causes hydronephrosis. So patient may present to you with even hydronephrosis without this local complaint. In stage 3C, it's metastatic, both lymph nodes, either in the pelvic cavity or in the para-aortic lymph nodes. Again, if you go further, then I'll share with you the next stage. Stage 4, if it involves the adjacent bladder or the rectum, and stage 4B, it involves outside the pelvis. That was the classification. You can all see that. And this is a change which has made between 2018 onwards. Before 2018, the tumor size more than 4 centimeter was limited to B1, B2. And now, if it is more than 4 centimeter, that is 1B3. Similarly, the stage 3, C1 and C2, it was involving both the pelvic lymph nodes and the para-aortic lymph nodes. But now, if it is limited to the pelvic lymph nodes, that's a 3C1. And if it involves para-aortic lymph nodes, that is the 3C2. That's why I always say once the patient comes to you for even simple abdominal lymph node pathology, we should look for two things, very, very important. Number one, if it is a male, look for the scrotum, because the seminomas, they come to you with the history of hydronephrosis because the lymph node sitting on the, or if there is a cervical pathology, please look for the downstairs first before you go for the biopsy, unless until the history is known to you. These were the old-fashioned investigations, ma'am, which used to be carried out, involving barium enema, IVU, lymphangiography, chest skeletal radiographs, and invasive procedure like cystoscopy, erectoscopy. Now they are no more required at all. Only two investigations I'll share with you, and you can reach the diagnosis. Number one, transabdominal ultrasound. Those who are doing the transabdominal ultrasound, even for CS cervix, please never jump to the TVS. Always start with transabdominal, because that gives a panoramic view and that gives a whole view of the pelvis, the adnexal area, the lymph node, the ovaries, and the uterine size if it is bigger. High resolution ultrasound, transvaginal ultrasound, TRUS. That is the upcoming modality. Let me share with you, it is indication in two things. Number one, those unmarried young girls who are suspected to be case of PCOD, we can't do the transvaginal ultrasound, and we can't have high resolution on transabdominal ultrasound. The best approach is go for transrectal. It is as high resolution as transvaginal to see the follicular activity and the endometrial activity if you are suspecting any girl with PCOD. Similarly, as the mass is grade 2B, it is involving the upper part of the vagina. As you introduce the probes, the patient starts bleeding, so you can go to the TRUS, and the sensitivity I'll share with you in the next slide. That is the upcoming modality, as we are using in the case of liver, contrast enhanced, because certain patients, they do have the, because the renal involvement serum creatinine is high, so this is a contrast 2C is given, exactly same picture as we see in the CT for the liver pathology, phase 1, phase 2, phase 3, 16 second, 20 second. I'll show you the image. And MRI. So ultrasound, MRI are sufficient, but sometimes you need the PET CT scan to stage the disease for metastatic disease, which cannot be seen by this simple MRI. How it looks on the ultrasound, very, very important. Normally, it is smooth in outline. It will be comparatively more hypochic. Hypochic means more black. More black means more vascularity. More vascularity means more blood flow. That means there is some mitotic activity going on. Heterogeneous involves cervix, may show increased vascularity on color Doppler. Normal cervix, they show minimal blood flow at the periphery, which is because of the arcuate vessels. Very minimal flow at the level of the interface. But in this case, you use a rich blood flow. Ultrasound cervical cancer stage clinically, however, ultrasound is useful. Either size is less than 4 centimeter or more than 4 centimeter. Very clarity, you can see that. You can appreciate the parametrial vision, which you can't see physically. Into the vagina, you can see that. Tumor invasion to the adjacent organs and hydronephrosis, sometimes patient present with the 3B stage. Just to show you this article published in 2008, look at it 14 years back, transrectal sound and MRI, they were compared with each other, and the sensitivity goes to 85%. So that is a tool which is totally non-invasive, bedridden, bedside facility available, no sedation, no risk of putting into the MRI. Just do the transrectal ultrasound and you can diagnose not only this local disease, even the parametrial involvement as usual. But the high resolution ultrasound TVS is equally good. But as I say, it is involved the vagina. Sometimes you get the limitations because of large mass, so you can use the alternative route. And that is just multiple papers, 2021, simple 2D, 3D, color Doppler, volume data meter, all are very sensitive as compared to that. Now look at this lady who came with history of foul-smelling vaginal discharge. Once I introduced the probe, it was very painful, she was bleeding. So look at the ultrasound abdominal. You can appreciate this endometrial, thin endometrial, but there's a large mass coming from downstairs, going up into the endometrium, and it shows a color Doppler rich blood flow. The more rich blood flow, the hypoc it is, the large it is, the transfer diameter. So once you find a color Doppler, low resistance, high diastolic, जितनी RA कम होगी, उतनी malignancy ज़्यादा होगी. इस RA पे 0.0.4, so that is very definitely it's a case of malignant cervix. That is just to show you the ultrasound sensitivity in the parametrium. Look at this article of 2021. The sensitivity of this ultrasound transvaginal or transrectal is 75%, while MRI is also equally 75%, and 25% with clinical examination, because you can put your finger in, you might have limitations how much is extending peripherally. Similarly, sensitivity, it has got 90%, accuracy 87%. So locally advanced cervical cancer can be diagnosed with excellent results on 3D ultrasound as well. Look at this ultrasound. That is for body of the uterus. There's a small amount of fluid in the uterine cavity because of the stenosis at the internal level, and there's a large mass. And look at the parametrium, which is extending on the lateral sides, suggesting it has involved the grade 2B stage. Update in the uterine cancer. Very important, once you're giving the treatment to the patient, P353, if it is raised, you don't have this facility available, but simple with color Doppler, they go side by side. If the vascularity is increased, the P3 is increased, that means it has got increased vascularity. जहाँ भी malignancy होगी, जहाँ भी growth होगी, जहाँ भी high activity होगी, वहाँ के area black होगा और वहाँ का blood supply बढ़ जाएगी. Now look at this area, large CS cervix, that is involving the rich blood flow, and that even indicates after the chemotherapy. अगर chemotherapy दे दी है, उसके बाद adjuvant therapy दे दी है, उसके बाद आपने blood flow देखा है, अगर blood flow कम हो गया, तो that means उसकी activity halt हो गई, control हो गई है. अगर blood flow बढ़ रहा है, that means you need to adjust your dosage or change the dosage. That is the new ultrasound available, contrast ultrasound. This is a slightly hypoc area, जो कि subjective variations है, मुझे नजर आ रहा है, किसी और को नजर नहीं आ रहा है, या मुझे नजर नहीं आ रहा, किसी और को. You can suspect this slightly hypoc area. The size is not big, but जब उसको टीका लगाएंगे 2 cc, तो within 16 seconds it's going to enhance. जैसे हम करते हैं ट्राइफिजिस CT करते हैं लिवर के अंदर, RTL phase में it enhance होगा. Within 52 seconds, it's starting washing out, and in 2 minutes, it has gone back to the hypoc structure. Typical picture of a hepatocellular carcinoma. So you can do this within, वहीं टीका लगाया, वहीं probe रखी, abdominal or TVS, and wait for 16 seconds, then 52 seconds, then 2 minutes. If it washes out completely, it's a definitely case of malignancy. Similarly, by using 3D ultrasound, you can measure the volume of the pathology over there. MR पे क्या है? There are multiple sequences which are very, very important. Dedicated MR protocol is often useful, and that is preferably done on 1.5 Tesla, not on simple 0.3 जो open MRI होती है, उसकी limitations हैं, उसके अंदर ये software हैं जो कि available नहीं हो सकते. It's preferably on 1.3 where you can do this dedicated softwares, and preferably normally you don't use contrast, but if there's any hydrogen area, we use the contrast. T1 weighted images carried out, that's the high signal intensity related to the surrounding normal tissues. These are software which I carry out. Look at this lady, just to show you, classification भी change होगी इसके अंदर figure के मुताबिक. 2018 में labeled as 3C2, which was basically in the 3C में. Look at this white color, that is a fluid. जब भी CS cervix होगा, endometrial C होगा, it has got different presentations, and one of the only presentation is fluid in the uterine cavity. If the fluid in the uterine cavity in a post-menopausal age with minimal discharge or false smelling discharge or bloody discharge, please think of the fluid should not be there unless until there is obstruction, and that obstruction should be looked after carefully by the surrounding cervix. And look at this cervix, you can appreciate this is hypo-intense and large, and look at the transverse view. On the transverse axis, you see this is the myometrium which is involved. The parametrium is going to be involved over there, and look at the lymph node. One thing important, lymph node, हम normal lymph node देखते हैं. Even everybody, all of us have lymph node. They are normal draining gutters. Any lymph node which is less than 10 millimeter, we take it as normal. But please, here the picture is different. If the shortest diameter is 10 millimeter, but the longest diameter is also less than 10 millimeter, it is rounded, it is hypokic, it's a malignant. Otherwise, if it is less than 6, length is 2 centimeter, that is taken as normal. Now look at the same patient. There is increased vascularity in the cervix, that's all, and there is a fluid in the uterine cavity. So that confirms the case of DNC. Same patient who had previously I shown you here, look at this, now we are doing the staging. वहाँ पे लोकल उसको diagnose किया कि वहाँ पे grade 2B में चला गया. But once you do this PET scan, you can appreciate this lymph node over here in the para-aortic regions. That's the aorta coming up, and they are the lymph nodes. So that means it has gone to grade 3C2. This is another patient with biopsy periendometrial carcinoma. Once you prove it, please always don't spare the cervix. Go for cervix. Look at this endometrium, this heterogeneous structure, but it's going down to the cervical level as well. So that means it's extending from the endometrium to the cervix. And that's once you do the CT scan, involving the bladder is distended, and bilateral nephrosis. It is a grade 4 C stage. ये मैं केस शेयर करना चाह रहा हूँ. It was a young lady, 36 year, madam. Professor Farooq साहब के लिए just to find out. This young lady, 36 years, she was having discharge. The biopsy was done on DNC, turned out to be endometrial CA just 2 months back. So she had got the partial subtotal hysterectomy. Dr. Taiba, ये आपके लिए है. This patient has a young lady, 36 years. She had DNC discharge. तो DNC पे साबित हुआ कि ये endometrial CA है. She had carried out subtotal hysterectomy. Right. Now she came back for 1 month. मेरा last slide. 1 month back, she came back again with history of discharge and following. Look at the MRI. There is still a cervix left over there, and that cervix shows heterogeneous structure. On contrast, it was enhanced. So this has got associated cervical CA in addition to the endometrium. She was done outside Lahore periphery. But my take-home message over here is, once you find endometrial carcinoma, please do look after the cervix as well. हो सकता है उसकी extension ना हो, उसके साथ associated हो. So this lady is after 1 month back with again the same complaints, and the cervix is there, which is showing heterogeneous texture. So that means this needs a resurgery or whatever the possibilities are. Updated ultrasound in uterine cervical cancer. You want to know the therapy follow-up. Again, you can do the ultrasound and see the blood flow. And that is very important. Intraoperative. Those of my colleagues who are sitting over here who are from the chemotherapy and other departments, once you are doing the brachytherapy, you have to plant the things. Please take the help of transvaginal ultrasound for 2 reasons. Because 5% complications are either you can perforate the uterus or you may not touch the wall. For that purpose, you can 100% see over here. Last message, any postmenopausal woman whose endometrium is more than 5.5 millimeter thick, and if you find any irregularity over here and you find the blood flow, isko please mat chhode. Must investigate that by doing DNC, whatever it is. But if you do the MRI, look at the smooth outline and look at the irregular line. Once you find any irregularity, that means it has got endometrial CA, which is invading this myometrium, which needs to be looked after. There is just latest article of January 27th, 23. 5-year survival ke liye, what are the criteria? If you diagnose in the early stage, she has got 92%. So early diagnosis, जैसे कहते हैं ना, कैंसर लाइलाज नहीं है. Similarly, breast के मामले में कहते हैं यहाँ भी वही है. If she comes inside, आपने पैप्स में लिया, उस पर diagnose किया, local surgery की, तो she can survive better. But if she comes early, 92%. If it has been spread to the local tissues, regional lymph nodes, it is 59%. But if it has gone to the distant parts, then the total survival of 5% is 5 years is 17%. So my take-home message is, clinical cervical cancer workup includes proper history and careful clinical examination, followed by imaging. Imaging plays a major role in the patient with cervical cancer. Number 1, in the diagnosis, treatment planning as a prognostic indicator, prediction of response to neoadjuvant therapy, and intraoperative as I showed in the last. And the modalities are ultrasound, MRI, and PET-CT, and that makes the diagnosis complete. Thank you very much for bearing with us.